This bite-sized ID is about antibiotic toxicity, specifically focusing on toxicities related to neurologic, cardiovascular, and hematologic adverse effects. My name is Nathan Everson. I'm a clinical specialist, infectious disease pharmacist here at Curling Clinic. We're going to start off by talking about neurologic toxicities. So one of the most common neurologic toxicities you see with antibiotics is neuropathies. A lot of different antibiotics have the potential to cause neuropathies. We see some of our mycobacterial agents like isoniazid and ethambutol, which are well known to cause neuropathies, but we also see some of our frequently used medications like linezolid, fluoroquinolones, and metronidazole, and even our triazoles have the potential for some neuropathy. In general, there's different risk factors depending on the medication, though prolonged treatment and advanced age are going to be some of the more common rationale you're going to see behind these agents. So often you're not going to see this early on in treatment or with short courses of treatment. You're more likely to see it with more extended courses. In the case of management or prevention for neuropathies, generally you're going to want to reduce the dose or discontinue the offending agent if that's possible. In the case of isoniazid, specifically supplementing with pyridoxine or vitamin B6 has been shown to prevent and manage neuropathy, specifically with that medication. And then making sure you're actually checking for it. One of the most common issues with neuropathies is patients not realizing that the neuropathy has anything to do with the medication. And so some examples of monitoring would be ethambutol, where we do baseline and monthly vision function tests due to the optic neuropathy potential. And then with linezolid, once we start getting longer courses, doing weekly peripheral sensory and checking vision function tests, because optic neuropathy is also a possibility with long courses of linezolid. We're talking like 3 months plus. So those are some potential examples of how you can implement some monitoring plans in patients who are on longer courses of antibiotics. Moving on to seizures, this is a much less common neurologic side effect. It's a concern a lot, but doesn't pan out to be that common of an adverse effect in practice. Very low incidence, and then a lot of the data is associated with specific case reports. There's not that many reviews. When we look at risk factors, we're generally looking at renal dysfunction, so higher levels than normal of the medication, and then any sort of pre-existing issues that lower the seizure threshold in patients. And then there's a potential, of course, for anti-epileptic drug interactions that could cause it just based on the drug interaction, not so much the toxicity of the medication. Penicillin has classically been associated with seizures. However, most infectious disease specialists will tell you that they've never actually seen a seizure associated with a beta-lactam. Particularly penicillin. We need really high doses of the medications and ideally something that's also lowering the seizure threshold before we can associate with a beta-lactam. So in most cases, it's not a major concern. One exception would be cefepime. It can cause some neurotoxicity with again, it's almost always associated with like an overdose situation, so higher levels than normal, but it can be associated with cefepime a little bit more frequently than some of the other beta-lactams. Generally, a dose reduction is all that's needed to kind of reduce that toxicity. Metronidazole can also cause seizures, though, again, not very common. The mechanism is unknown. Our fluoroquinolones have the potential for some seizure causing, acting as a GABA-A antagonist. But again, not very common to see this as a major toxicity, though can happen on occasion. And then moving into ototoxicity. So ototoxicity was more common with some of our older agents or the ways that we used to dose medications. Risk factors are going to be advanced age, renal dysfunction, and then multiple ototoxic agents. Aminoglycosides have the most association with ototoxicity, and this was much more common when you use traditional dosing of aminoglycosides, where we dose 3 times a day, lower doses. Since then, we've changed to doing single dose aminoglycosides on a given day. So high dose once daily. When that happens, you're able to give the patient more free time with the troughs being much lower, and then you see much less toxicity in that setting, both renal as well as ototoxicity. So lower troughs are definitely going to be what association with improved toxicity profile with aminoglycosides. And generally, once dose, like what we sometimes give for cystitis in the outpatient setting, are not going to be associated with significant ototoxicity. Macrolides are probably the most common agent just based on how frequently we use them, and sometimes some cases use them for extended courses. Definitely cause ototoxicity, and I've seen these in practice multiple times. Sometimes reversible, sometimes not in some patients, but it generally is going to be one of the first things you look at in someone who's on a long-term medication that macrolides have that potential. And then quinine, I'm not using this very often at all anymore, but does have the potential for some ototoxicity. We're going to kind of transition into cardiovascular toxicities now. And starting off with this is QT prolongation, which is a common question that comes to any pharmacist's practice about evaluating for QTC lengthening with some of our antibiotics. So when we think about risk factors for torsades in patients, we see electrolyte abnormalities, QTC over 500, heart failure, and then probably most importantly, multiple QT prolonging agents. In general, a single QT prolonging agent has a relatively low risk of pushing a patient into an arrhythmia like torsades. However, multiple agents can have a synergistic effect. So when we look at our agents here, the most common ones that we are associated with, macrolides, fluoroquinolones, and triazoles, we see, the high end of the range is a 15 millisecond increase in the QTC, which isn't very much. However, once you start combining these agents, maybe the patient is also on amiodarone or other things going on, we can see this change be a little bit more exponential. Particularly with macrolides, azithromycin is going to be the agent that does it the least. And when we kind of move on to our fluoroquinolones, we see Cipro is having the least effect on changing QTC. And when we move over to triazoles, they all have the potential for a similar amount of QTC lengthening, with one important exception, which would be isavuconazole, which we only use in kind of special circumstances, but that case does shorten the QTC. Something that's come out more recently in the past decade or so is the potential for fluoroquinolones to cause an aortic aneurysm or dissection. The mechanism is still somewhat under investigation. However, the assumption is it's associated with collagen degradation, which some of the other fluoroquinolone side effects are also associated with this. And when we look at potential risk factors for patients, advanced age, prolonged treatment, peripheral vascular disease, and then if they've had a history of any sort of aneurysm, all potentially increase the risk. Another reason the fluoroquinolones are often not our first line agent due to the amount of toxicities that we can see in patients who are taking fluoroquinolones. And now we're going to move on to our hematologic toxicities. So when we think about our hematologic disorders, we're going to touch on aplastic anemia, agranulocytosis, hemolytic anemia, and then thrombocytopenia. Generally, the mechanism can be differentiated between more of like a direct toxicity, either from the drug or a metabolite of the drug, or it's more of an immune reaction. In some cases, we don't actually know the cause, but we may have assumptions. So starting off with aplastic anemia, where we see kind of a significant drop of multiple cell lines for patients. Our causative agents, we can see this with sulfonamides, dapsone, but probably the most common agent that we see it with would be linezolid. And by saying the most common, it's still relatively rare. Linezolid doesn't cause a lot of blood dyscrasias until we're looking post 2 weeks of treatment. So most short courses of linezolid are relatively low risk for any sort of drop in any cell lines. It's generally considered an idiosyncratic reaction. It doesn't seem to be dose dependent. There can be a latent period before the onset, and sometimes the damage to the cell lines continue even after discontinuation. In most cases, linezolid induced toxicity does improve after discontinuation of the medication, but it's really important to kind of continue monitoring aggressively for linezolid for any sort of long courses. In terms of agranulocytosis, where we see a decrease in our mature myeloid cells, we can see multiple agents doing this. Beta-lactams, valganciclovir is well known to do this. Specifically, imipenem has some association with it, our macrolides and sulfonamides. There are other case reports down below, but less association than these other agents. This is a place where we're not entirely sure if it's always direct for some immune-mediated toxicity, and generally we're thinking really long courses, so over a month of treatment before we start seeing some of these side effects. For hemolytic anemia, this is a little bit more well-known blood dyscrasia for some of these different agents. Most commonly, this is in the presence of a G6PD deficiency, and the agents we're going to see most commonly do this are dapsone, nitrofurantoin, and primaquine. In general, nitro is not used long enough to really see much of this a side effect. It's generally 5-day courses for uncomplicated cystitis, but dapsone and primaquine both can be used for extended durations in patients and do have an association. And getting a G6PD is really important in those situations. Ribavirin's well known for causing hemolytic anemia. Fortunately, we rarely use that anymore, but we also can see it with our rifamycins, sulfonamides, even fluoroquinolones have the potential to cause it, so it can be seen with other agents. So keeping in mind our G6PD deficiencies as being one of our main concerns for hemolytic anemia, when we're starting medications like dapsone or primaquine, making sure we establish the patient's G6PD status. So we have that deficiency plus a drug-induced oxidative injury, and then we see that erythrocyte hemolysis. In terms of the classification of G6PD enzyme variants, we can see a severe G6PD deficiency all the way down to mild to none, and then kind of talks about what your chances are of causing a hemolysis with different levels of deficiency. And lastly, we'll talk about thrombocytopenia. We see thrombocytopenia inpatient on a frequent basis because there's so many things that can cause thrombocytopenia on an inpatient stay. Uh, in terms of causative agents, because it's so multifactorial, a lot of agents get associated with thrombocytopenia. So we see a pretty extensive list here of different agents that can cause thrombocytopenia. Linezolid shows up as being one of our more common agents, and this again doesn't really occur until after 2 weeks of therapy. Thrombocytopenia is a stronger association with linezolid than an aplastic anemia is, so that's the most likely blood dyscrasia if linezolid is going to cause it. That said, linezolid is still a very safe medication, and this is a pretty infrequent side effect, particularly with short courses. But we see a lot of other agents that we commonly use, like rifampin, sulfonamides, fluconazole, acyclovir, all have some potential for thrombocytopenia or have reports of thrombocytopenia. And There may be immune, maybe non-immune, and it may be a little bit shorter of onset than we see with some of our other blood dyscrasias. So that concludes this bite-sized ID on antibiotic toxicities. Please check out some of our other videos we have on our antimicrobial stewardship website for more educational opportunities. Thank you.